talk about breasts.
Let's talk about you and me.
Let's talk about all the good things
and all the bad things.
Welcome to another episode of BoobTube Podcast. Thank you for joining us. I am Chantel.
I'm your best friend, Jaleesa.
And we're here with another very informative episode for you. This episode continues our conversation with our two-part series of Breast Cancer Awareness Month. As we are in October, we have special guests joining us who are from the medical field who are enlightening us on ways that we can continue to protect our breast health and ways that we can continue to seek resources if we need them. But first, let's head to the streets with BoobTube on the Move. On a scale of 1 to 10, 10 being the highest, how important is breast health in America, in your opinion?
I think it's really important, breast health. Because I think someone died in our family with breast cancer and stuff like that.
So with America, like on a scale of 1 to 10, 1 being low, 10 being highest, how important do you think Americans think breast health is?
Say 9.
9, okay. Why do you say 9?
I don't know, honestly.
Okay.
For me, I think it's a 9.
Okay. On a scale of 1 to 10, 10 being the highest, how important is breast health in America, do you think?
I don't think some Americans take breast health seriously. For instance, my sister, I have to be on her 24/7. I say, this a new year. Did you do your checkup? She said no. It's like she's very laid back. I'm like, you can't afford to be laid back.
Yeah.
A lot of things is happening. You can't afford to be laid back.
Yeah.
So.
And even with she's still not.
I say, you know what? You're gonna learn when something like this happened to you. That's when you're gonna realize that any little thing, you're in the doctor's office.
Yes. Yeah. Well, kudos to you for still sticking with it too.
On a scale of 1 to 10, 10 being the highest, how important is breast health to you?
Oh, 10, 100%.
Okay, we got to keep those titties in check. All right.
This is another one regarding breast health. On a scale of 1 to 10, 10 being the highest, how important is breast health to you?
Definitely a 10. I feel like, you have to listen to your body, and I feel like your breast can tell you so many different things that's going on with you. So I definitely think it's important to always be checking things of that nature.
All right.
Have you heard of mammography?
Is that some type of exam or something?
Mm-hmm.
Yeah, I probably have. Yeah.
Mammogram?
Yeah. That's what it is. That's like that word sounds familiar. It's like it's the same family.
Okay, kudos to the guy for knowing, some good tips to help women support their breast health.
Yes.
I thought maybe he was gonna go for the third. Maybe he was gonna say something with wearing the right bra or something like that. But kind of gave up. But it's okay. He gave us 2 good ones.
I think the first one when he said doctor was kind of broad too, because I think you can go to your regular physician for one, but if you also don't do your mammograms or annual mammograms, that could have been 3. So I think he it was broad. So
yeah. Others as far as what, not sleeping with a bra.
We heard that,
and stuff. Yeah. So everyone has their different ways, but we, of course, we always talk about self-exam. So making sure you're doing that. And we've had doctors in the past that were guests that always say that it's important to know your breast and know your body. So just your body overall, but for sure with your breasts, you want to make sure that you know them so that if you do encounter any sort of irregularities, how would you know if you never paid attention?
Exactly. So self-breast exams are definitely important. And another reminder, we talked about this in an earlier episode where we were talking about conditions that are not breast cancer related. Check it on the first, or that can be your monthly reminder to make sure that you are doing your self-breast exams.
Mm-hmm. So, have you had a mammogram?
Yes, with my family's history, I've had they call it baseline mammogram.
Okay.
So I started that probably late 20s when I started that. And then I actually need to schedule one for this year.
Don't forget.
But don't forget. So yeah, I do get mammograms, and I'm approaching that recommended number at this point. So
The big 4-0.
yeah, I still got a couple of years though, but I said
We know.
approaching.
We know, approaching.
Yeah, but yeah, I've had them.
Okay. I mean, I have not.
Okay.
I don't have a family history either, so that's that too.
Yeah. I mean, it can be uncomfortable, but it's a necessary uncomfortableness is how I view it. I remember going around when I was planning an event for breast cancer awareness, I think it was last year, and just talking to different women about things and just amazed at how many women just did not want to get a mammogram because they say, I heard it's uncomfortable. Well, I mean, what about your health? Like that would be uncomfortable going through something if you didn't have to go through it, if you can prevent it. So I think about it that way.
Yeah, I mean, like not breast exams, but like pap smears and stuff. Those aren't the most comfortable either.
Some women don't get those.
Spread eagle on the table.
Some women avoid those too.
You're right. They do. Having a baby.
Sometimes you just can't avoid that.
Shoot.
It just happens. I said sometimes.
I'm living
well,
proof.
In today's climate, you ain't got no choice. So
I'm living proof. It happens.
But yeah, it can be like they do just smush your breasts together.
Mm-hmm.
So
yeah. So I've heard. Like I said, I haven't experienced it myself, but understand it.
Yeah.
I think my mom has gotten them, and like my grandma, aunt, stuff like that. But yeah, not me.
Well, and it's good that your family history doesn't, dictate that you need to have it early.
Right.
And so that's good. But I do know that there, with the advances in technology and just medicine overall, even with my family's history, my mom, she took the BRCA gene test. BRCA, that is a gene that tells if you are a carrier of breast cancer. Mm-hmm. And so her mother passed away from breast cancer. She did not have the gene, so they're saying I don't have the gene. So I don't, it does help they have different tests and different preventative measures that can help families now better understand their history and whether or not they need to continue taking preventative measures. But all women need to take some type of breast health measure regardless of their family's history, just because it doesn't have to run in your family for you to get breast cancer.
It can start with you.
Yeah.
And it can come from many things.
Yeah.
So do make sure you do that. One of the things you mentioned was the pink ribbon thing.
Oh yeah, it's a pink washing.
Yeah,
is a scam apparently. And I think I've been so I remember I went out to eat with a friend. I guess it was during October. We got pink martinis. And so what pink washing is if people are just representing breast cancer awareness, but they're not really giving back to organizations. They're just saying, hey, buy this and
it's pink.
It's pink. But there's no true, I guess, donation being made. Right. So be mindful of that. That there are people out there trying to scam people during this time of month as well. So and if you are give to a reputable organization. I won't give out any because you can go out there and look for themselves, but see how long they've been around and see what their mission is, and you can make the decision from there.
Makes sense.
Yeah.
That pink washing is unfortunate, but it makes sense. I feel like they do that with other things as well, like other months or things to celebrate.
Yeah. People are always looking for ways to make money, and then even at the expense of people who are trying to do the right thing.
Do the right thing. So, as Chantel mentioned earlier, we do have some guests that we have to join in on the conversation to give us some more insight, as this is their respective profession. So we're again excited to present you with this information. So let's see what they have to say. All right. So we mentioned that we had some more guests here for part 2 of our breast health series. And in order to learn some more about getting your annual mammogram, how that can be life-saving, we have here Dr. Makisha Miggins, who's a breast surgical oncologist, and we have Catherine Beeman, who was a patient care coordinator at Texas Health Allen Breast Center. So please welcome them to BootTube.
Woohoo! Woo, welcome. I am glad that you are here and I am eager to learn from you.
Yes,
Absolutely.
definitely.
Happy to be here.
Yeah,
Yes.
thanks for having us.
Of course.
Yes,
Right.
thank you for making available, especially during this busy time as we are in Breast Cancer Awareness Month. I'm pretty sure you're probably being pulled from multiple directions, but thank you for making time for BoobTube and our audience. So I would like to start with Cassie. Just introduce yourself and how you got into mammography.
So I started back in 2015, and I honestly was kind of out of school and didn't really know what direction. And so I was like, let me try this. So I went into the field of mammography, not really even knowing what I was kind of getting myself into, real honestly. And it kind of took off from there. So I was there for 7 years and directly in the breast center. So I was working with patients face to face, doctors, oncologists, pathologists, radiologists, and then other departments within the hospital. And absolutely loved it. Had a blast doing it. And yeah, I wish my coworkers would tell me, oh, you should keep going and do this and get your degree and all this stuff, your x-ray and all this stuff. And I was like, it's cool, but I really like talking to patients. Whereas they were just kind of doing the technical side. I really enjoyed helping and being in a more supportive role. But yeah, that's kind of my foundation, my background.
It's really cool. At least you're honest about what you like to do.
Oh, yeah.
That's very important.
Very
Yeah.
much so.
All right. And Makisha, could you tell us about yourself and how you got introduced into oncology?
Well, hi everyone. I'm a breast surgical oncologist, and I basically kind of found my way to oncology. When you're going through training as a general surgery residency, which is the path to becoming a breast surgical oncologist, you get exposed to a lot of areas. You basically operate almost on the entire body except for the bones and the brain, essentially. During that training. And so I found myself really gravitating towards the oncology patients. It's more of a field that's multidisciplinary, meaning that you get to work with so many other areas. Like I'm a surgeon, but just as Cassie was saying, she works with pathologists, the medical oncologist, and you kind of navigate the patient's care. And so I think part of the reason why I became a surgeon, I do like a little bit of immediate gratification. So, when you're doing surgery, you usually, not always, but usually, if you have a good outcome or bad outcome pretty early on sometimes, especially in training. But also you see the problem and you fix it with like hands-on intervention. And that's kind of where I knew that I liked things from in medical school. I knew I liked procedures. And so that's what led me to surgery. But I really liked breast surgery, one, because it's women's health primarily, although men do get affected with breast cancer. But it also is an opportunity to just meet someone at the beginning of their journey, whether it's that abnormal mammogram or whatever it might be, or they already know they have a diagnosis of cancer, and try to lead them along the path in a stepwise fashion just really appealed to me. And in most cases, the outcomes are pretty good. So that also is something that was appealing.
That's really cool.
Oh, I love hearing about both of your journeys.
Mhm.
For both of you, do you recall the youngest person to receive a mammogram or your care in your experience as a patient care coordinator or as a surgeon?
You can go first, Doc, if you want.
Oh no, please. For me, the youngest patient that I've had was 22.
Okay.
It's pretty young.
For me, not as young, but I would say 27.
Okay, and I only asked that question because I know breast cancer is becoming more prominent amongst younger women, and I know they're saying 40, get your mammogram, but women in their 20s, early 20s, that's really young. So I'm just a huge advocate on young women being mindful of checking their breasts and making sure they're aware of the importance of breast health.
Yeah, I think you bring up a really good point, is that we don't start screening till age 40. The reason is because, of course, the majority of patients with breast cancer aren't under the age of 40, thankfully. But just because you're not ready for a mammogram doesn't mean that your doctor shouldn't be checking your breast or that you shouldn't be checking your breast. And so I think we recommend breast cancer screening with breast cancer exams, not with imaging, starting in your early 20s, at least by 25. But most people couple them with their early visits to the gynecologist. So by somewhere between 21 to 25, people should be starting to get clinical breast exams, meaning that your doctor is doing the exam.
Yep.
Thank you for that.
Bring me
I was
back
gonna
to
say,
that.
and oh no, I was gonna say
Oh
just to,
no. Go ahead.
no, what were you gonna say?
I was just saying, it brings me back to on here. I mentioned one time, the first time I had a breast exam, which was technically during a physical in high school, and it was a bit of a horror story because it was just really uncomfortable for me. So
Oh,
yeah, I had hit the doctor.
I can only
Like, I
imagine
wasn't
if
trying
you're
to, like I kept hitting the doctor. My mom was in there. It was just uncomfortable.
I can only
yeah.
imagine if you're in high school getting a breast exam, you don't even know like if there's that. I mean, was there any introduction to it? Was there a reason for the breast exam? Because
I don't
usually,
know.
yeah, that would make
I
me
think your
feel
mom
very
was in the room.
yeah.
Yeah, it was a lady. It was a young lady, but I don't know if I just thought it was part of the physical.
Mm.
But because I was only maybe in like 10th grade, 9th or 10th
Mhm.
grade at max, and I needed it for dance for to be on a dance team. So I don't know, but it was very uncomfortable, and my introduction to breast exams was interesting, but I got past it. But just being touched like that was kind of weird to me at that age.
Yeah.
Were they explaining things that they were? I'm interested because I've been in a well woman's exam and they're as an adult and they're telling me what they're doing as they're going on. And
Mhm.
as an adult, it just made me feel so much more at peace, even though I've had those before. So do you remember if they were talking to you along the way, explaining what they were doing and why?
I think she did, but it's not like they didn't check my vagina or anything. It wasn't a well woman's. It was
Oh.
It was
I
just
Oh, so
physical
she just
yeah.
went straight for him, huh?
form to
Is
sign
it,
off to say that you were in good enough condition to participate in the dance class, I assume.
I guess it was. Is it because I was busty? Did they feel like
Maybe.
we need to look at her breast? No.
Make sure that they are can sustain the exercise and activities. That's
Oh,
weird.
Yeah, that's yeah. That
We'll
well,
was
just
that's
say you
such
had
a
a
that
very
very
questionable
thorough
nowadays.
physician, pediatrician, physician, whoever that might have been, was a little bit ahead of the game. But usually we don't really do that unless there's a concern.
Mhm.
Oh well, I might have knocked her out of her position that day. No, I didn't hit her hard, but I did hit her. So weird. Okay,
Oh.
Cassie, what were you saying though?
No, I think I was just piggybacking off of that, just making sure a lot of times people would ask that, well, I'm not supposed to get a mammogram until I'm 40, but so what am I supposed to do, And basically what I would let patients know is that you should be going annually to somebody anyway, obviously a family health doctor or an OB, even if it's a pediatrician, because I think some pediatricians take patients up until they're 21 or
Mhm.
something like that. So I would just always say, make sure that once you get to a certain age as a woman, they need to also be doing a breast exam, on you as well, because they're going to be the ones to kind of feel around, know what they're looking for. And then, of course, just in the shower, laying down, those regular examinations on yourself too, as well.
And we learned
About
more. Oh, go ahead.
I was gonna say something about the self-breast exams. I recently was on, it may have been American Cancer site, one of those sites, that they're not recommending self-breast exams because it's like they are women are becoming alarmed because they're feeling things. And so, but that I did see that the recommendation, oh, don't feel yourself. I'm like, that's stupid. Like, and who else is gonna know your body except for you?
Yeah,
Right.
they've kind of gone away from the term of self-breast exam, even though we still say it and utilize
Mhm.
it, to self-breast awareness.
Mhm.
So which still means that you have an awareness of your body, right? You pay attention to yourself, you notice if there's something different. But for some people, examining their breast invokes anxiety.
Mhm.
And so then people will think they feel things, even if they don't feel things, or, or you feel something that feels abnormal, but it's actually normal breast tissue. And so I think it was a little bit of that kind of drove that. But I still tell my patients, I tell everyone, you should be aware of your breast. Whether it doesn't mean that you need to be checking them, every week, but you should be aware of changes, and mindful of those things.
Because you would be surprised of how many patients that their partner found their lump. Or I had a patient one time, she said, yeah, I was sleeping and I turned a certain way. You know how you're asleep, but you're awake when you kind of make some movements. And she was like, I felt something that wasn't there. And so that's what prompted her to come in. So just like you said, just advocating for yourself. I can't tell patients that enough, just making sure that you know what's normal for you, because at the end of the day, yes, you can go to the doctor, you can, but if you're not speaking up, if you're not like familiar and comfortable with your own body, then how can somebody else kind of, help you?
I saw some lint on my nipple the other day.
You said lint?
Lint.
Lint. Oh, okay. I thought that's what you said. I was like, huh?
I'm just saying, like, I look every day, especially like when I shower, is just something. So I was in the mirror and I was like, my nipple looking weird. And then I showered, then I looked in the mirror after that and I was like, oh my God, was my nipple looking red? Is something coming out of it? And then I looked and I was like, oh, that's just some lint from the towel.
No, but you bring up a good point.
Only you.
Yeah, that's so funny though, but that you look at yourself. And so I find that a lot of women, for whatever reasons sometimes it's usually insecurities about their own appearance or something like that, won't look at themselves. But it's so important to look at yourself in the mirror or look down so you can see what's going on.
True.
Even if it is just lint.
No, seriously. I've got stories for days, but there was a patient, and I know we'll probably get into some of that, but she did not want the technologist looking at her when she was doing the exam. She was like, don't look at me. And she was like, well, ma'am, I have to position you. I have to, and so if they're like that with, somebody else, which I get, sometimes patients are weird with their own bodies for whatever reason, so yeah, you can kind of run into those things, believe it or not, with breast health a lot. So
I didn't even think about that, but it makes sense.
Yes. Yeah,
yes.
people have a lot of trauma. And so even though you're doing something that is in your right as the physician or the whatever healthcare provider you are, or tech, whatever the case may be, is that people come in with a whole lot of trauma, a backpack full of things, and you have to be able to help them through those issues and try to find a way to still accomplish what you need to, usually it's by explaining what's going on in more detail or asking them what they would be comfortable for, sometimes letting them guide your hand for them. It's just, it's not always very straightforward. So you can see how patients sometimes shy away from going in to getting the imaging and the exams they need because of maybe they were touched inappropriately as a child. Maybe they're getting touched inappropriately in their adult relationship. Maybe someone has said something to make them feel insecure about themselves. And so it takes a little bit of, I think, patience and understanding and trying to understand why the patient is expressing whatever they are telling you.
Those are some valid points to consider, especially when you're thinking about some of the barriers and why particularly we're definitely encouraging women to be proactive in their health, but we're not asking, I guess, maybe the right questions as to why they may not, be comfortable going to get a mammogram or an exam, so those are definitely some things to consider.
Have you dealt with that with some of your patients and like helped them through certain things to where they felt comfortable?
Yeah, so I once had a patient that actually she did not feel comfortable with the physician that she saw before me. And so kind of refused an exam by that physician. I'm not quite sure why, but was very adamant that she wanted to come see me. So she transferred within our institution to my clinic. And I think that it was a level of comfort. She had a lot of difficult social structures. And so she said that she didn't feel comfortable in the room, that, you know, people were accepting of her because she didn't have as many means as some other people might have. And so she didn't feel like people were going to be that accepting of her. And so sometimes I think that patients are trying to gravitate to who they think might accept whatever baggage they're bringing in with them. I hate to call it baggage, but I mean, it's like the backpack full of things that we all carry around every day. And so what it teaches me when that happens is that as patients, and I applauded her for this, is that you have to be comfortable with whoever you're seeing, right? It's not an emergency usually. So if you're not seeing in an emergency situation, you got to see who's there, right? But if you're trying to establish a care relationship with someone, you'll never be able to be transparent and open and have that open communication that you need to have between a doctor or physician and whatever the healthcare provider might be, and yourself if you're not comfortable.
Right. Yeah, I was gonna say, yeah, and same. So we would have, my main radiologist is a male. So sometimes, very rarely, we would get a patient call to schedule and they would ask, well, who's the radiologist? And, you know, we'd let them know and they would be like, well, I prefer a woman, you know, so we would have to either get them to a different location or we would have to wait until he would leave. And then we would usually have a female radiologist that would rotate in. And that was helpful for them, you know, being able to know the doctor's schedule. So I could, okay, let me try to get you with somebody, that way you're more comfortable. And that was very helpful. You know, sometimes, unfortunately, they wouldn't tell us until they got there. And it's like, well, this is the doctor, so you can cancel your appointment, or, you know, and I think some patients maybe didn't realize or understand that there are male radiologists. And so when they get to that point of, you know, if it's anything extra that they need, like a diagnostic mammogram or a procedure, that it could very well be a male. So in some cases, and I mean, we were always in the room with them. He was like, hey, somebody needs to be in here with me at all times. But, you know, still, there are some women who just aren't comfortable with that. So we do try to accommodate on the front end as well.
I think that's good to hear. That alleviates some of the worries, and you all being proactive with that is very comforting.
Yes. Glad we touched on that subject.
Yeah.
Absolutely.
Did you all, or do you all typically see an increase in patients during the month of October since it is breast cancer awareness, or is it typically about the same?
Absolutely an increase
Okay.
on the front end, as far as, you know, the screening mammograms. And I think that's great because, you know, we see pink everywhere this month, you know, even, I mean, I know like the NFL, they changed it to like crucial catch, to kind of catch all of the, I guess, more cancer awareness in general, but still, you know, I remember a few years ago, I mean, it was nothing but pink on the field, and, you know, Susan G. Komen, they're advertising kind of everywhere and even in the store. So it's a good reminder. But yes, absolutely. And then I know at a lot of breast centers around the country, they will do special things for the patients to kind of entice them to come in. So we used to do like gift baskets, or we would give out like things to every patient. Like, if you come this month, you'll get a t-shirt. One year we did like a pair of socks, you know, so you'll get something like a cup or something. Then that kind of makes it a little bit more, you know, enticing to come in and get it done.
You, Makisha?
No, same. Well, I don't think we give out anything during the month of October or anytime during the year, but definitely this time of year, there's so much heightened awareness. So you definitely see an influx of patients, usually from this point on to the end of the year. For a couple of reasons. One, because it's October, but also because a lot of people have deductibles that are or have been met.
I just said it. Yep.
To keep it real. So they're like, oh wait, let's go get this.
Let me go get that done.
Yeah. But I always say that but people with health insurance, screening mammograms are free. So your health insurance, the average health insurance covers preventative medicine at about 100% usually. So people are like, oh wait, let me go, because some places will run specials, or I think even though we make it more accessible during this time of year too, because we know you'll see more mobile mammographies going around the city and things like that, because we're trying to meet the people where they are.
Right.
That's what I
One of
said.
That's like one of Jaleesa. Yep, she always said.
Yeah,
That'll
not
meet
you
people
becoming
where
a
they're at.
technologist and then you add that onto your van.
Yes, I meet people where they're at mentally,
See?
because everyone's not ready for bra fitting, and
Yeah.
physically at where they're at. Which also leads to the next question. When I say not everyone's ready for their bra fitting, not everyone's ready for mammograms. So what are things that maybe in y'all's experience y'all have done to encourage women to get their screenings I guess at any given time, but whenever it's necessary?
Yeah, usually I ask people, right? So part of my job is to ask people, have they done their healthcare screenings, whether it's breast, colon, anything like that. So I ask, but then I often remind them that ignorance really isn't bliss. And I think we think it is, but it's not, right? What you don't know really could harm you. And so I also remind them that the pain is temporary. I think that's the biggest driver that keeps people away sometimes, is either shame, fear, or concern for the pain, or discomfort, I like to call it, is very temporary, but it is present. And so you take someone who has one bad experience with their mammogram, and they may not come back for 5 years. So I think we have to take all of that into consideration. I also encourage my patients, because the majority of my patients are breast cancer survivors, or, and we consider survivorship starting the day you're diagnosed with cancer. So, and I say, you could use this as an opportunity to tell a friend, if they're working still, to remind people, at work or whatever, to get their mammogram, or even if they feel comfortable sharing their story. Because then that also helps people, because people often are afraid of this long drawn out story, and they see, like, people think cancer and they immediately think death, to be honest. But so that's why it's helpful when people who have these amazing stories of, oh, I went in, I had a small procedure, the biopsy, what that was like, all those things, if they can share their positive experience, it can always help someone. And even their negative experience can help someone sometimes.
Right. And just again, to piggyback off of that, I always would tell my patients, the sooner the better. The sooner you get in here, that could be the difference in everything, your treatment, the size of this, how long you're out of work, whatever the case may be. So, if you come in for your screening, then let's say you get worked up and it's all the way to a biopsy, and then you do have to have surgery to have this area removed. That's just better, because we're catching it sooner, versus you waiting, not knowing. And then, later on down the road, this thing has maybe grown, it's, costing you more time, you're away from your family, your job, all of that kind of stuff, because that's the other part of it too, the financial side, it's definitely fear, but then there's also, hey, I got to be able to feed my family, hey, I'm working, I have young kids, I can't do all of this stuff, and so that was kind of a battle too. But just, the sooner the better. Truly what they say, early detection is key. That can make all the difference in your treatment.
I think you touch on a really good thing, is that people have lives and they have a lot of responsibilities. So, and the way that healthcare is set up today, we don't necessarily meet everyone's need, right? A lot of people, I didn't realize this, and it sounds horrible to say out loud, but I didn't realize that, everyone isn't afforded the opportunity to, just come in late to work. This is like years ago. Obviously, I realize this now, but before, probably when I was like 20 or something, 21, I didn't realize that everyone can't just say, oh, okay, I need to take off early today. Some people have to miss the whole day of work or a whole shift if they need to go to the doctor. And it's not like we're 24/7 staffed. And so I think that's why it's helpful when places have like Saturday imaging, or occasionally we'll have after hours imaging, to be mindful of those people who have other responsibilities that often take precedence over their own health care. And in my experience, most women will put everyone else's health before their own. They'll go get their care, but it might be delayed because their child or their husband or spouse, whoever it might be, had something else going on.
Absolutely. I saw that so many times. There was again, so many stories. There was a patient, I was younger than her at the time, but the cancer, it was bad. It was very obvious it was bad. And we asked, we were like, if you don't mind, why did you wait? And she was fine. She was like, I didn't have insurance.
Mm-hmm.
I didn't have the resources, and people don't even realize there are centers that you can go to and they will do everything from start to finish. Honestly, for free if you qualify. And she was just like, I didn't know where to go. I didn't know what to do. I thought it was going to be a lot of money. And I don't know what ended up happening to her, but it was, by the time she got to us, it was definitely stage 4 already. She was my age now, which is 34. And it was really sad to hear that it wasn't because, she didn't not know that it was there. It was just simply because she just didn't have the funds for it, So definitely putting other things in front of it. The financial side is huge. And it's unfortunate.
Mm-hmm. Definitely. That's very interesting. Other things y'all bringing up things that I didn't necessarily think about before when it comes to this, but it makes all the sense, obviously.
It does.
For Makisha, I have a question. So what type of treatment does an oncologist provide?
Well, there are different types of oncologists. As I said, I'm a surgical oncologist, so I provide the surgery. I remove the cancer. But we have medical oncologists who give the drug therapy. When I think about breast cancer treatment, as I tell my patients, I break it down into like 3 groups. There's drug therapy or medications, whether that's chemotherapy or a pill you take every day to try to reduce your risk of developing a recurrent cancer. There's a surgeon like myself who's going to go in and remove the cancer. And then sometimes you even need a radiation oncologist who will deliver radiation treatment to help, again, reduce the risk of cancer recurrence. And so fortunately, we don't all have to do all of those jobs, that we definitely have our different subspecialties, but my job would be to remove the cancer.
Got it. And for you, Cassie, how would you describe the day in the life of a patient care coordinator?
Yeah, absolutely. Or I could also walk you kind of through, because my job was like a catch-all. I mean,
Okay.
I was setting up sterile trays, I was in biopsies, wire localization.
Okay.
I did a lot of stuff. But as far as like the technologist, basically, let's say it's a screening mammogram, I'll kind of just walk all the way up until we maybe get to oncology. So you walk in, you have a screening mammogram that day, and now we do, or they offer 3D mammography. So 2D is, what was the standard, and it's still 2D pictures are still being done with 3D as well, but it's just a better, more in-depth picture of the breast. What kind of happens is the machine takes pictures of the breast in slices. And so that way the radiologist can see a better picture. Also, less painful for the patients. And there was another point, less painful, and could result in fewer callbacks. So I'll get to the callbacks. So basically, once you finish with your screening mammogram, they take the 2 standard views of each breast, and then you leave. And then the radiologist, he will read those images, and then let you know if you need to come back for additional imaging, which is a diagnostic mammogram, or if everything is fine and we'll see you in a year. If you come back for a diagnostic mammogram, then they will take specific pictures looking at specific areas or whatever it is. So if you have dense breast tissue, if they found a little nodule or lump in the breast, whatever it is that the doctor can't, quite definitively know, then they'll have you come back in for that. Let's say you need to go even further. So they've determined that it's in the criteria to have a biopsy. So then you'll come back, you'll get a biopsy done. They make a small incision in the breast, take some breast tissue, and then that gets sent off to a pathologist. And then let's say now it's positive and, you need to have surgery to have this removed. Basically, we will that's where my part is done. And then we send you on, tell me your name again.
Makisha.
Makisha. Dr. Makisha. That's where we're going to go after that. And then she will take over from there.
You brought up 3D. With my family's history, my mom suggested that I do that. This was a few years ago.
Mm-hmm.
But my insurance would not do it. Like, I'm actively advocating for my breast health. And they were like, no, you're too young. So, yeah. So I do roll my eyes at some of the stuff that I encounter, but.
Yes, I was going to say, and there's just kind of ways that you have to kind of trick the system. So number one, when you're under 40, you do have to have an order from your doctor. So, basically you would, talk to your doctor, say, hey, I have family history. Hey, I'm feeling something in my breast, whatever the diagnosis is. And then they would just write it out. And then you would go to your breast center and they would do it for you. Now, it starts getting kind of tricky because patients would be like, well, it should be covered. It's covered, but you still might have a deductible that you have to meet, that's the insurance side, of everything. But yes, if anytime you're feeling something in your breast, anytime that, let's say you have a pretty strong family history, let's say my mom was diagnosed when she was 40. Basically, you should be starting your mammograms at age 30, 10 years before mom got diagnosed. And that should be covered. You might have to pay a little bit depending on your insurance plan, but yes, I get the 3D thing too. There's like a whole code, but typically, I don't know how recent that was, but I think the major insurance carriers, Aetna, United Healthcare, Blue Cross, they should be covering the 3D mammograms because now it's pretty standard. There was kind of this shift change where, like, back in 2015, you had to be at like a top of the line, like breast center, to have 3D mammography. And then now pretty much everybody has 3D. That's like the standard, or tomosynthesis is what they call it. So like it should be standard, and more insurance companies should be covering it. But again, I think when we say cover, it may not be at 100% like a screening mammogram is.
Now it is actually. So you're right, like 2014, 2015, it wasn't, but then there was legislation, I think, that came around about 2018, 2019, that allowed for, mandated that insurances cover 3D or tomosynthesis with screening mammography. So before, people used to have about a $70 copay, depending on where you went, somewhere between $50 to $70 additional fee. I shouldn't call it a copay. It was an out-of-pocket expense to be able to get it. But then now, as you said, the major insurance carriers primarily cover it. I think I've only come across some instances where some versions of Medicare, depending on what that is, the person is signed up for, they do not have to cover the 3D, at least for a screening, but they will cover it if it's diagnostic imaging.
Yes.
So once the patients are passed on to you, Makisha, how does that look in a day in the life for you?
Yeah, so the patient, shows up at my office usually with one or two things. Either there's someone who came in because they had an abnormal mammogram, and so they or their doctor said, oh, wait, you should go see a specialist. And then I order all of that diagnostic workup like Cassie talked about. And then for the majority of my patients, their cancer is diagnosed or their abnormality is diagnosed by a needle biopsy, whether it's by ultrasound or mammogram. So when they come to me, the vast majority already have a diagnosis of cancer. And so then my job is to explain their cancer to them, review their images. So I have to work very closely with the radiologist because and the language that the radiologist uses matters to me a lot. So when I read the report, it's obviously more in depth than the report that patients get when something is normal. Usually you get a letter. If everything is fine, you get a letter saying your mammogram was great, see you next year. Essentially, that's what it says. But when I get the report, I'm looking at the report to look at a few things. Are the breasts dense? Where's the abnormality located in the breast? What's the size of it? Is it a mass, or is there something called calcifications that they see on the imaging? And then I have to ask myself, well, how large is it by looking at the report? So there are a lot of details that the radiologist is trying to communicate to me. And then I also have to look at the images and, of course, examine the patient, because you can't just get it all from the report. So when I'm prepping for clinic, I'm reviewing the report, reviewing the images, and then finally I get to see the patient. But by the time I see the patient, I'll know some things, what type of cancer they have usually, what is influencing the growth of their cancer, things that we look for called biomarkers, because that tells us something about how we need to treat the cancer. Those biomarkers are estrogen, progesterone, and a protein called HER2. But it tells us a little bit about how the medical oncologist will then guide the treatment process for the patient. I also find from that information, from looking at the mammogram, the size of the breast, because the size of the breast relative to the size of the cancer really, in a lot of cases, dictates what I'm going to do. So, or what I'm going to offer the patient. Ultimately, what I end up doing sometimes is it's really dependent on what the patient's desire. There's a lot of autonomy and shared patient decision making in breast medical oncology and surgical oncology. And so what I'm trying to decide, is this patient a candidate for a lumpectomy because the cancer is small relative to the size of their breast? Or is this someone who I can't safely offer a lumpectomy because the cancer is too big, and I'm going to have to only offer them mastectomy or removal of the breast? So those are the kind of things that I'm looking for or thinking about before I even walk into the room to see the patient. And then, of course, gathering their history, kind of what led them to that point, and then getting a good look at the skin, because that tells me something about what's going on with the patient. And then deciding if I need to send them to the medical oncologist first because they need that drug therapy or medications, whether it's chemotherapy or something before we go to surgery, or if I can take them to surgery first. And so depending on what that ends up being, then either they go get their medication first, the chemotherapy that they need, and then I see them back later to take them to surgery. But together we decide if the patient's going to receive a lumpectomy or a mastectomy. And then we together decide if that patient will be a candidate for reconstruction and should be referred to a plastic surgeon.
Thank you both for sharing. Provide some insight into what your patients or what patients go through and that whole process. So it's a lot that goes into all of that.
And the different options.
Yeah, definitely the different options. It's good to be aware of all of that.
And there can be so much going on in the breast that you have to kind of be very detailed oriented, because you can have one thing at one position in the breast, another thing in another position. And when the radiologists perform their biopsies, they put these clips or markers in the breast. And that's very important because I need to correlate this finding with that marker. And it helps for everyone else who sees that patient in the future when they go get mammograms to know that someone's already biopsied this. It's benign. We don't have to pay that much attention to, or, oh, it's changed. Let me look at that. So I think that also brings up a really good point, is that when you're transitioning from one center to the next, and you're establishing to get your imaging somewhere, it's very helpful if you can bring prior images. And, patients often think that we're just giving them a hard time or making them jump through unnecessary hoops. But the real thing is, like, if you were to read a book, you wouldn't just start in the middle. You want the beginning or the few chapters before that to set the story up. And so the prior images really set the story for us. It lets us know, oh, this is something that we don't need to biopsy, and it prevents a lot of unnecessary testing because we know the history of something. So
Makes
just
it
to
easier
plug
on everyone
imaging.
involved.
Yes, makes it easier for everyone, including the patient. Most of the time, it's the patient, because it can lead to unnecessary biopsies and increased cost.
Yes, that was probably 60% of my job was
Oh my
getting prior
goodness.
mammograms. Oh my gosh.
Yeah.
People jump around.
You hit it
Yeah.
right on the head, literally, because I had patients come from all over, and they would be like, I'd be like, well, where did you go? I don't know. And I'm thinking, you don't know who felt on your breast? Come on now. Like, you don't know where you went. You don't know where, and then they would, finally figure it out. And they're like, well, why? Why do you guys need this? And it's like, well, just like you said, it paints a picture for the doctor. He needs to see everything, because, let's say you had I think one of the hardest ones was kind of those people would switch. So they would, I hate to say this about patients, but they would kind of like try to run a little game, because they would need to come back in 6 months for a follow-up, but they would switch and come to us, and thinking that, oh, they're not gonna care, they're not gonna get my history, and we would be after their history. And they would be like, well, why do you need it? Well, we need to know what we're seeing. And then we would get the report in, and it's like, well, you never showed up to them for your last mammogram. So now it's a diagnostic, and the reason being, again, cost. Well, I want it to be a screening. Yes, I understand that, but you have something that they're following. So we don't, yes, we might be taking more images of you, but you never followed up. And so we have to also do our due diligence and make sure that we're looking at whatever this is. That way we know what's going on, in case, we don't want to miss anything, because then you'll be even more mad if we miss a cancer or something like that. So yes, that is hands down, like, please take things with you, pick up your records if you're moving to a different city or state, or at least know where you went. That way we, the facility can get, in contact with the last place and get it all coordinated for you.
Yeah, sounds like there's stuff to do on our end as patients and on here as well. So keep that in mind, folks. Is there a correlation between cancer and nutrition, and cancer and physical health, in you all's opinion, or in you all's professional expertise?
Well, I think so. When we think about the American Cancer Society, especially patients who have been diagnosed with cancer, and this is not just breast cancer, this is, all comers for cancer, the recommendation for people is 150 minutes of exercise a week, or 30 minutes 5 times a week. When you say 150 minutes, it sounds very overwhelming, but 30 minutes 5 times a week has been shown to reduce the risk of cancer recurrence. Having a diet that is well balanced. And so by well balanced, I mean, which is something I have to work on myself, a plate that is 2/3 plant-based, plant and fruit-based, and 1/3 of that, meat. We're not meant to just eat meat. We are meant to eat the colors of the rainbow, as they say. But also limiting our alcohol use. I think that is something we see not just with breast cancer recurrence, but even when you think about liver cancers and other cancers, is that people drink more than they think they do. And so the recommendation usually is 1 serving of alcohol per day at most. And so a serving, is like that 5-ounce pour, or 1 ounce of liquor, or like a 12-ounce beer. But you don't think about it that way, because, when you're out with your friends, you're enjoying. And so I like to tell people that binge drinking is worse than drinking once per day when you think about it. So you can't say, oh, I didn't drink Monday through Thursday, so let me make up Monday through Thursday on Friday and Saturday or on Friday night, because these things do matter. So I think you can't necessarily eat your way out of a cancer diagnosis, right? If you have a high risk for cancer development, but you can do things to help try to modify those risks, and especially modify the risk of recurrence.
You know, so audience, if this sounds like it's repeating itself, I know sometimes we have to hear things more than once, more than twice, or more than 3 times sometimes, but yes, these factors do play a part in reducing the risk for cancer.
So I would say, what are your observations when it comes to cancer returning?
Well, there are certain cancers that are going to be more likely to come back than others or have a higher risk of recurrence. What we know today is that just because you have cancer doesn't mean it will come back, but it always can come back. And so I think that often is a driver for patients when they think about removing their breast, is because in their mind, if I remove the breast, then I won't ever have to deal with this again. But the truth is that it doesn't work that way. Cancer can come back in the skin. It can come back in another organ. It doesn't have to just come back in the breast, in an intact breast, if you will. And there are cancers that are more aggressive than others. And we learn this, that also cancer in a younger population tends to be more aggressive than, let's say, the 70-year-old who develops breast cancer or any type of cancer with that respect. And so I think we gain a lot of insight these days on cancer treatment, and it's been tailored to how aggressive certain cancers are. There are tests now to try to determine what someone's risk of recurrence is, based on looking at we call it genomics. So you're looking at the makeup of the actual tumor to help predict what someone's recurrence rate is and what their treatment should look like. So I think it just tells us that although you shouldn't always have cancer at the forefront of your mind if you've been a cancer patient, but you can see how people don't ever really get away from cancer, because we know and we tell them it always can come back. And that could be 10 years from now, or could be, 15 years from now. I've seen patients who have been cancer-free, for 20, 30 years, and now they have a new cancer in the same breast or a cancer in the other breast. And that happens to people, unfortunately.
Thanks for that. What are you all's recommendations to help prevent cancer from returning, if at all possible?
So we say to reduce the risk. We don't guarantee that we can prevent it from recurring, right? And so I think the first thing that I tell people is to follow through with the treatment plan. What happens is sometimes patients will think that they can pick and choose. So like I said, there are sometimes 3 buckets, if you will, of care that someone may have to go. They may have to see the medical oncologist, the surgeon, and the radiation oncologist. And we all have a component. And so they might say, well, I removed my breast, so I'm not going to take the drugs that the medical oncologist recommended because I don't have the breast there anymore. But the drugs aren't just for the breast. They're trying to protect the entire body from a recurrence, or to adequately treat the cancer. So sometimes just removing the cancer doesn't mean that you've completely treated the cancer. Or some people will say, this comes up often sometimes with our patients who decide to get a lumpectomy or to save their breast. They'll do the surgery for the lumpectomy. They'll take the medication that the medical oncologist prescribed, but they'll say, oh no, I'm not going to do that radiation. And if you're saving your breast, the vast majority of those patients require radiation after the lumpectomy. And so I think some of it is treatment fatigue. Some of it is trying to create their own package, if you will. I think a lot of patients these days are like, don't tell me what a standard of care treatment is. I want to tailor my care to me, and that's great. We want you to be able to do that. But we also know that there's some guidelines to help us tailor that. And part of tailoring the treatment doesn't necessarily mean that we are okay with you skipping out on portions of the treatment. But obviously we can't mandate that for anyone. People are adults and they get to make their own decisions. But I think that's the first thing that I would tell people is you have to ask yourself, did I do everything in my right? Because you don't really have any control beyond that. And so if you took the medication, did the procedure, did the radiation, whatever was recommended to you, then you've done all that you can do. But I think that those patients who we often see back sometimes are patients who didn't follow through with the treatment always. And then of course, there are some patients who are unfortunate in that they did do everything we asked, but their cancer was just more aggressive and returned.
Okay. So we like to end on a positive note. So are there words of encouragement that you all can provide, whether or not it's someone it's just time for their screening, or they've been battling cancer, or they've beat cancer, whatever stage they're at? Any words of encouragement you all have?
I would probably say, just like I kind of, touched on earlier, the sooner the better. So again, going to those annual appointments, if you're under 40, and then when you are 40, just making sure that you start getting your mammograms, and just being aware of your body. That's key. I would always, tell my patients, it's you and me together working through this. So like I said, we can only do so much. We're going to do our part at the doctor's office when you come see us, but also just being aware of what's normal for you and what's not, and just, I know I would have patients once we did tell them their diagnosis, they would, well, I'm not going to tell anybody. I'm not going to say anything. And I would be like, if there's just, I would always encourage, if there's just one person that you can just kind of let it all hang out with, and you can just tell, don't keep it all bottled up inside, because I think with anything negative or what do they say, an idle mind is the devil's playground. Like when you kind of cut yourself off from everybody, it just seems worse. You just keep going, your mind is playing tricks on you. It's just not a good thing. And so if you just got one person, you don't have to tell the whole world. You may not want to tell your kids. I understand that, but just telling one person and just kind of share things with, and so that somebody can be with you and support you, because it turns into a lot really quickly. There's different doctors, there's different appointments, there's all these things coming at you, and it's a lot for one person to keep up with, and so just having that one person just kind of be an ally for you is what I would recommend.
Perfect.
Yeah, I think that's really good advice. Just to echo that, I would tell people, don't let fear keep you back. And that's for anything. I gained so much strength from my own cancer patients. I'm there to help them, but I find like they really do positively impact my life and put a lot of things in perspective for me. But the one thing that I know is that even if they're fearful, they aren't held back by it. And if they are held back by it, they are usually open to, some positive encouragement. So don't let fear hold you back. Don't let fear keep you from taking care of yourself. Use your voice. Find a place where you feel comfortable expressing your voice. If you feel stifled, you just won't open up and get the care that you need. And then also remember that you're not alone. I think sometimes in healthcare, the day is busy. There are a lot of patients. It's sometimes very fast-paced moving day. But I find that especially in oncology care, and even with some really good primary care physicians, is that we all want the best for our patients. And we all want to give them the best care that we can. And so if there's something that they can do for you to help your care process, let them know, because there's often so many resources to tap into, whether it's support groups. There are groups that help you even get to the mammogram. I think there's some things where people will people will go with you for people who are scared. So don't be afraid to utilize the resources that exist.
Okay. Definitely good
Thank-
advice.
Yeah, thank you both for that.
Yeah.
A lot of good
Thank you guys for
gems
having
there.
us.
Yeah. All righty.
Oh,
Well,
also, I
where can
guess
we find you all?
she likes to find you.
You can find me at MD Anderson. I work there primarily. I have a clinic at our Sugarland location, but have worked at both our main campus, our medical center location, I should say, and our Sugarland location, and operate in at our medical center location. You can also find me randomly around the city, sometimes at breast cancer events and community service events.
And me, I'm just in the Dallas area. Like I said, I don't work there now. But anytime my friends have questions, or if anybody is just asking, or, this time of year, somebody might post something, I'm like, "Ooh, I know, I go get seen. If you have any questions, I can answer them." So, yeah, I'm here. I'm on Instagram. That's about it.
Where can they find you on Instagram if they have questions?
So I'm at Cat Renee at home, and cat is with a K, Cat Renee at home. No underscores or anything, just straight through.
Right. Well, we hope that some people, if they have their questions and if they're looking for a breast surgical oncologist in their
Hey.
East area, or just wanting to come here for some medical care, that they'll reach out to you. So again, thank you all for joining us. This has been very informative for us alone. So for sure, for viewers, I know that they'll enjoy this information for sure.
Well, great. Well, thank you so much for having us. It's wonderful to have this type of podcast for patients, just to have this access to open information. It's the real info that people want to know. So it's good work you're doing.
Thank you.
Yes, absolutely. I love it. Boob
Trying to
tube is
cover
awesome.
all the breast needs.
Yes. Thanks, breasties.
You're welcome. So that was a lot of great information that I'm sure is very useful, especially at this time of year. We're very strong when it comes to the breast in October. That there are many things for all of the months of the year, but everyone knows about October being Breast Cancer Awareness Month. So be sure to pay attention to your breast health year round, not just October. October is just a month where we really highlight this, but as we've discussed before, you should be paying attention to your breast health year round. So make sure you're doing that. If you have an appointment to make it. If you haven't gone at all, just start anywhere with calling a doctor, starting with your self exams. It's just a part of life. So make sure you're doing it. Make sure you like, comment, subscribe. We know that we have a lot of people out there that can relate to the information that was provided in this information, and we would love to hear it. So be sure to share it with us and tune in for next week's episode. And also, don't forget that we have BoobTube merch. So make sure that you visit our website and shop with us. We have a lot of bountiful goodies that are there. Till next time.
Bye.